Granger, Lars, Wallentin, welcome you two.
Thank you.
Well, Chris, you just presented the results of ARISTOTLE here at the late-breaking trials. Very exciting. Lars, why don't you set the stage for us? Who were these patients? What was the disease state that you studied in ARISTOTLE?
Yeah, I mean, these are the usual patients studied in atrial fibrillation trial. When we embarked on the trial, it was really the first time that a big global trial with double-blind treatment using double-blind warfarin was used. So it was a challenge in the design. We didn't know that much about the dosing either. There was no phase 2 trial. So it was kind of an educated guess to start it. So it has been a very exciting trial to perform. Of course, the patients were those with atrial fibrillation that had an increased risk of stroke, and they should be a certain proportion of warfarin-naive patients. 40% of the patients are really not exposed to warfarin before, and then we have 60% that have switched then from warfarin to the new treatment. And they were followed for 1.8 years. And we really had big expectations, but of course the primary objective was to show that Apixaban was non-inferior, as good as warfarin. But we had 3 more objectives. We set out to show that it was also superior in stroke reduction, stroke prevention in comparison to warfarin, and we achieved that. And we had as our third target to show that this should be achieved at a lower risk of bleeding, and we achieved also that. And finally, this was translated into a reduction in mortality, and even that was significantly achieved. So it has been a great result, even overwhelming results when we saw them for the first time in June this year. And now we have it published, presented publicly, and open for discussion of all. And I am sure Chris, who has been presenting the details, would like to review some of the details with you.
Well, thanks, Lars. Yes, but that's a great summary. But there was this 21% relative risk reduction in total stroke. And that was mainly driven by a reduction in hemorrhagic stroke. There was a 49% relative risk reduction in hemorrhagic stroke, but also some reduction in stroke that was ischemic or uncertain type. And then there was this very impressive, at the same time reducing total stroke, so better efficacy, also this very impressive reduction in bleeding. So major bleeding reduced by 31%, enormously statistically significant, and really quite an unexpected finding to have both of those together with one dose, both a reduction in stroke and a reduction in bleeding. And then perhaps not surprising, and I think you'll put this in perspective of the other trials, Lars, but when one reduces intracranial hemorrhage, not surprising to reduce mortality, but it was gratifying to see for the first time really in a rigorous prospective fashion looking for a reduction in mortality, a statistically significant 11% reduction in all-cause mortality. This also was in the context of a drug that was better tolerated than warfarin, so very well tolerated, fewer discontinuations of Apixaban than warfarin, and this was also consistent across all subgroups. We had 21 pre-specified subgroups, and none of them approached statistical significance for the interaction, for the primary outcome, so a very consistent effect across geographic region, warfarin naive, CHAD score, renal insufficiency, all the important subgroups, age for this particular population. So as Lars says, we're really delighted with these results, and a question that comes up oftentimes then is now we have 3 trials that are completed and 4 trials that are completed and 1 ongoing looking at these novel oral anticoagulants. And now what do we make of the whole field? And Lars, you're the perfect person to address this, having led 2 of these trials.
Yeah, I think one issue that can be emphasized it is that we are comparing to warfarin, and the quality of warfarin treatment is variable between different countries, between sites, and we are today also presenting the results in relation to quality of warfarin treatment in relation to time in treatment range. And the time in treatment range at the median in the Aristotle trial was 66%, and that's rather comparable to what was achieved in the open label RELY trial, and it is comparable to what has been achieved in previous atrial fibrillation trial. So I think the quality of care in the warfarin arm was rather high. It was higher than in the ROCKET trial that with another 10A inhibitor recently presented. So we are proud about that and happy. And when I present the comparison in relation to centers INR control, it turned out that we have really no significant differences in you compare Apixaban and Warfarin in centers with more poor INR control, and also in those with better INR control we have consistent results. So I think this is one advantage of this trial, that we really have good documentation that irrespective of time in treatment range, we see these benefits of Apixaban. There was somewhat less of this consistency with dabigatran, where it seemed that concerning mortality and bleeding, there were more of an effect in centers with poor INR control. So of course the comparator here is always important. I think another advantage of Apixaban is the safety, because this is a prophylactic treatment. Patients with AFib and an increased risk of stroke, they don't have many symptoms, and we don't like the treatment to create symptoms. So we had with Apixaban a substantial reduction in gastrointestinal bleeding, and that is in contrast to what was seen with dabigatran that increased the risk of gastrointestinal bleeding. And the same was seen, as a matter of fact, with rivaroxaban in the ROCKET trial. So it was definitely safer. There have been a lot of discussion about a signal of increase in myocardial infarction seen with oral thrombin inhibitors like dabigatran. And with Apixaban, there was definitely no such signal. There was slightly less myocardial infarctions, not significantly so, but definitely no signal of an increased risk. And overall, there was no safety issues that we have been seeing, no differences in any adverse events, no liver signal. And so therefore, I think that really physicians can be very confident and feel comfortable when starting a patient on Apixaban, that they now have a convenient, safe, and also more effective treatment than Warfarin. So that's kind of a summary, that I think there is an edge to Apixaban concerning safety, and with about the same efficacy as the previous best new compound, dabigatran.
One of the questions that comes out is always, who were these patients? What was their CHAD scores?
So as Lars said, this really was a typical population, very similar to RELY, Lars, wasn't it? That the mean CHAD score was 2.1. About a third of these patients were CHAD score of 1, a third were CHAD score of 2, and a third were 3 or greater. So this really does cover the entire spectrum. And Lars, another question that's come up is, given the results of RELY, ROCKET, ARISTOTLE, will there be a shift, do you think, in what we believe should happen with patients who are CHADS 1?
Yeah, I would think so. And we were looking into patients with CHADS 1 with dabigatran versus Warfarin. The effect seemed relatively even larger in that group. And I think it's very consistent with what we see with Apixaban, that we have a striking effect in CHADS 1. So I think aspirin is definitely no alternative. And we need to remember that we have the ARISTOTLE trial comparing Apixaban to aspirin and seeing a dramatic reduction in stroke. And so therefore, I would say that aspirin is definitely no first choice any longer in any patients with AFib and any increased risk of stroke. Maybe we will come down to CHAD 0, but that's more doubtful, and that has never been tested.
In the United States, one of the barriers that we've got, and I think worldwide, is cost, because
Sure.
these new agents are quite expensive. So another thing we're hopeful for is now that we anticipate that there will be more drugs on the market, that maybe there will be some downward pressure on cost, because these results are so important, I think, for patient care, that it's a shame if we have some of these barriers to patients getting the benefits from the drugs, such as very high cost.
Yeah, and I think if there was no cost issue, I mean, Warfarin would definitely leave the market immediately. No one would start any patients on Warfarin. Why should they? They have a more convenient, safer, and better treatment. So I think cost is the only issue, and we really hope that maybe if medication is more cheaper, maybe the companies might gain even more by having more patients treated with it.
Well, you know, I did a back-of-the-envelope analysis of the cost-effectiveness of DABI when you had presented your results, and when you have the kind of mortality reduction you had, you'd have to treat about 200 patients, and I think the societal cost of that was about $220,000 a year. That person goes on to live about 6 years after an event, and so it ended up being about $30,000 per year of life saved. And that does seem to be kind of in the mid-ground of cost effectiveness data. But of course, the NICE committee pushed back a bit. I think there's a lot of debate about the cost of warfarin monitoring. And you know, it's not just the cost of sending the lab test out. I mean, there's a lot of the cost of nurses and doctors and the cost of people not showing up, and all these analyses discount the cost of a patient losing time from work and coming in and traveling, et cetera. So I hope that we'll have a very thoughtful approach to analyzing what the true cost of warfarin is.
And I think you need to bring into this also the cost for care of strokes, the cost for taking care of bleeding. I mean, there will be a reduction in cost for bleeding. And I mean, these analyses cannot be done in a double-blind trial where all the Apixaban patients needed to come back for INR controls, etc. And maybe we should also take into consideration that more patients will tolerate a treatment like Apixaban in comparison to warfarin. There are many patients stopping warfarin because of the inconvenience of the treatment, because of the side effects. If you get more AFib patients protected, then maybe there is even a gain of using Apixaban because you have less strokes in the society, and that's a very large cost associated with strokes.
Well, when you factor, you know, a stroke is about a $100,000 cost in the United States, and a major bleed's about a $5,000 to $10,000 cost. And when you factor that in, that number comes down to about $16,000 per year of life saved. So, yes, we really are cutting down on medical cost by reducing stroke and reducing major bleeding. Well, guys, congratulations. Wonderful work. You know, I still wonder, we really have reduced bleeding, and we really have a safety signal here. Do we really have an efficacy signal? Have we reduced ischemic events?
So maybe, Lars, I could finish with just the number of events prevented per 1,000 patients treated.
Mm-hmm.
So what we saw is per 1,000 patients over this 1.8-year period, there was 6 strokes prevented. 4 of those were intracranial hemorrhage, but 2 were either ischemic or uncertain type of stroke. Mm-hmm. Then there were 15 major bleeding events prevented, mm-hmm. and 8 deaths prevented. Mortality is death is very common in this elderly AFib population.
And that's 8 deaths, that exceeds the number of ICHs. So
it
the mortality
does.
reduction isn't all attributable to reducing those ICHs.
That's correct.
So, I mean, when starting out with these AFib trials, no one imagined that we really should be better than warfarin. Right. And there is a reduction in stroke, and there is a nominal reduction in ischemic stroke. And I think I would not switch to prevent one more ischemic stroke to lose on the bleeding side. I think the safety side is so important when you persuade the patients to take a medication that the patient doesn't even believe that he needs. So I think the gains in bleeding is really one of the big things with Apixaban in relation to other, to have the best of both dosages of the Bigatran. That's how we see it. So you get the benefit in stroke and of the high dose of the Bigatran, and you get the benefit of reduction in bleeding, and even more reduction in bleeding than with the low dose of the Bigatran. And it's a little bit unbelievable that we have a treatment that provides these benefits. And maybe we should remember that the worst strokes are the hemorrhagic strokes, much worse than an ischemic stroke, and we are preventing the worst strokes.
Well, you know, it's called Aristotle, but a physician at that time was Hippocrates, and one of his sayings was "do no harm," and you're actually doing less harm here with this trial. Well, guys, congratulations. Excellent work. Thanks for joining us today. And thanks to all of you for joining us here at Duke TV and Clinical Trial Results live from ESC 2011.